Hello, I'm Benjamin Keller, and this is my oral comprehensive exam entitled 60 Seconds to Safety, using brief narrative bridge-ins to prime nursing students for adverse drug reaction recognition. This is in partial fulfillment of my Master's of Science in Nursing Education at Colorado State University, Pueblo. I want to start with a story. Susan is a newly licensed nurse working in an understaffed skilled nursing facility. During a busy shift, an aide reports that Mr. Smith, a brand new admission, has a heart rate of 125 beats per minute. His medical record is incomplete, and the provider gives a verbal order for propranolol. Susan administers the medication. 20 minutes later, Susan finds him clutching his chest, struggling to breathe, and his oxygen saturation has fallen to 83%. Susan immediately recognizes that something is wrong, but she cannot connect the patient's sudden respiratory distress to the medication she just administered a few minutes earlier. A senior nurse rushes in, quickly identifies the beta blocker-induced bronchospasm, and initiates emergency treatment. The patient survives. But later, Susan sits quietly in the break room, replaying the event in her mind. She knew propranolol's mechanism of action. She had passed her pharmacology exams. Yet when faced with a deteriorating patient, she failed to recognize the medication-related cues unfolding right in front of her. So what went wrong? Well, this raises an essential question for nursing educators. How do nursing educators help students move beyond recalling what medications do for the NCLEX and prime them to recognize and respond to adverse medication reactions in clinical practice? We'll explore that today. We'll also explore the significance of this problem, the case study with a novice nurse educator named Professor Pat, the PSCOT question, the NLN core competencies, AACN essentials, the ANA ethical considerations. We're going to look at some contemporary research, theoretical foundations, as well as some teaching practice guidelines. We're going to look at ethical, technical, and safety considerations, revisit our case study with some methods and results, explore some gaps in leadership, and look for educator and leadership implications. And finally, we'll summarize this and take a look at our references today. Let's explore the significance of this problem. Medication errors and adverse drug reactions remain major patient safety concerns. Pharmacology is overwhelming, and it can impair student self-efficacy and knowledge retention the way it's currently designed. New graduates often struggle to recognize medication-related cues and translate that pharmacology knowledge into clinical practice. One study showed that 75% of medication errors can be attributed to novice nurses. Traditional lectures support knowledge acquisition, but provide limited opportunity for clinical or contextual application. And finally, clinical judgment begins with noticing cues. So let's take a look at a case study for Professor Pat. Professor Pat is a novice nurse educator. He's a new adjunct pharmacology instructor hired at Nurse Susan's alma mater. He's never taught before, and he wants to increase patient safety and equip his students for clinical success following graduation. He starts in just 2 weeks and works full-time in a clinical setting as a nurse. He's inherited a dense, lecture-heavy course with a high failure rate and low student self-confidence or self-efficacy. He's got no time for curricular redesign. His goal? To improve ADR cue recognition, self-efficacy, and knowledge retention without significant curriculum redesign. So what evidence-based strategy can Pat implement immediately? We'll explore that today. And this brings us to our PSCOT question. Among pre-licensure nursing pharmacology students, how does the use of a 60-second narrative-based BOPPPS Bridge-in focused on adverse drug reaction recognition compared with traditional lecture introductions in medication-related clinical cue recognition, self-efficacy, and pharmacology knowledge retention over one academic term. We'll break that down. As a novice nurse educator, Professor Pat recognizes that his responsibility extends beyond simply chalk and talk, beyond delivering pharmacology content. The NLN core competencies call nurse educators to facilitate learning, promote learner development through assessment and feedback, and encourage and engage in evidence-based educational practices, among others. Similarly, the AAC in Essentials emphasizes clinical judgment, patient safety, and evidence-informed nursing and educational practices. And finally, the ANA Code of Ethics encourages practicing and teaching with compassion while promoting the emotional and physical health and safety of our patients and students and advancing the nursing profession through scholarly inquiry. Motivated by these professional expectations for nursing educators, Pat began searching for practical strategies to help his students recognize adverse drug reactions, build their self-confidence, and retain essential pharmacology knowledge in order to enhance their clinical judgment and provide safer patient care. Pat starts his literature review with Kershid et al. It's a 2023 study. This study examined 75 different studies involving almost 12,000 pharmacology students across multiple majors that included nursing, medicine, dentistry, and pharmacy programs to identify the major and key challenges in pharmacology education. It's a realist review which helps to draw practical conclusions from large data sets. They found some key challenges. Number one, pharmacology is the difficult subject. It's true. That traditional methods like lecture limit opportunities for knowledge integration and clinical application, and that interactive learning, enjoyment, and motivation optimized students' cognitive load. And many successful educational strategies utilized scaffolding or constructivist learning or approaches to help students overcome these challenges. And they noted that optimizing cognitive load helped with educational impact and positive outcomes. So Professor Pat decides to use a narrative-based approach aimed at cognitive cueing to help his students recognize those adverse drug reactions. However, there are limited high-yield studies on narrative hooks in pharmacology education. So Pat initially explores case-based learning, which shares some of these features. Chen et al. In 2025 is a level 1 systematic review with a meta-analysis. They examined 11 studies representing medical and pharmacy undergraduates and compared case-based learning to lecture-based learning. And they found that case-based learning yields significantly higher exam performance, enhanced communication and collaboration skills, enhanced clinical practice skills, and overall higher class and student satisfaction. The authors recommended the integration of real-world clinical cases, contextualization, to help bridge that theory and practice gap. And this in turn leads to better outcomes than lecture-based learning alone. So that begs an important question. Why not use case-based learning if it's better than lecture-based learning? Well, that's a good question, and one answer can be partially found in Maia et al. 2023. This was a level 1 systematic review of meta-analysis that examined 41 studies representing 7,667 medical undergraduate students on their academic performance. Like Chen's study, they found that the case-based learning approach is significantly better than lecture-based learning in terms of exam performance, student motivation, and student interest. However, they also found that case-based learning increases instructor burden and significantly, and it is not significantly better than other time-consuming and time-intensive methods, be it sim, problem-based learning, team-based learning, or the like. So It's better than lecture, but it's not a standout. Postulating that case-based learning is effective at bridging the theory to practice gap because of contextualization and clinical narratives, Professor Pat wants to use a brief case study to help his students recognize adverse drug reactions, and he explores the BOPPPS method, which uses a narrative hook or a bridge-in to set up the rest of the teaching session. So in a 2024 study by Lee et al., it was a level 1 meta-analysis of 13 randomized controlled trials involving nearly 3,000 students enrolled in nursing fundamentals. They found that the full BOPPPS model, as referred to on the previous slide, was significantly more effective than lecture-based learning at facilitating student mastery, and it boosted theoretical practice and self-learning scores as well as student satisfaction. The BOPPPS method was shown to provide students with a structured, systematic learning process that enhanced their analytical problem-solving skills and aptitude while creating a seamless transition from theory to practice. It sounds like we're on the right track here. Zhu et al. In 2025, they conducted a level 1 systematic review and meta-analysis of 16 studies involving more than 2,300 health education students. And these researchers found that the full BOPPPS model showed significant improvement over lecture-based learning at boosting final exam scores, student satisfaction, classroom interaction, learning initiative, clinical thinking ability, and learning. This model also provided students with a clear roadmap and a cognitive structure to aid in schema production and reduce the cognitive load that they experienced compared to lecture-based learning. However, and this is a big however, it still takes time to modify a curriculum for the full BOPPPS model. It's not as much as problem-based learning or case-based learning, but it's time that Professor Pat doesn't have as a new adjunct faculty member starting in a couple weeks. So he wonders what would happen if he simply borrowed the narrative bridge-in concept as an easy-to-deploy micro-intervention instructional strategy. Through his literature review and knowledge of educational theories and theorists, Pat develops the following interventional strategy and hypothesis. His intervention, he's seeking an easy-to-deploy microeducation strategy as a time-strapped, newly hired adjunct. So he's going to use a 60-second NGN-style exemplar to prime his students for clinical cue recognition on adverse drug reactions at the start of each lecture. These brief narratives will act as a cognitive anchor for subsequent learning content. Professor Pat's working hypothesis is this, that novice nurses often overlook crucial medication cues due to clinical stimulus overload. That's Benner. But clinical judgment requires noticing. That's Tanner. This brief narrative bridge-in serves as a cognitive anchor to minimize extraneous cognitive load. Sweller. Properly scaffolding the recognition of adverse drug reactions will help students succeed in class, thereby increasing their self-confidence and self-efficacy, and ultimately improve patient safety outcomes. That's Bandura. So these are our theoretical foundation. First, let's look at Tanner. Tanner has a clinical judgment model with 4 phases. It's noticing, interpreting, responding, and reflecting. Clinical judgment starts with noticing. Noticing. Clinical narratives prime this noticing phase. They say, hey, look, this is important. Benner has the Novice-to-Expert, and novices need scaffolding patterns to help them distinguish the salient or the important data from the clinical noise from all the other stuff. These narratives can help provide that scaffolding to say, hey, look, this is important. And finally, Bandura's self-efficacy model points students to saying, hey, you can be successful in recognizing these ADRs, these adverse drug reactions in class, and that can help you build the confidence you need for safe clinical practice. And all of this together are some different approaches to some constructivist approaches. And that repeatedly in our literature review demonstrated significant efficacy in pharmacology education. Narrative pedagogies like this bridge-in concept can provide that necessary scaffolding by connecting new information to meaningful clinical applications. At least that's Pat's theory, hypothesis. A number of the studies in the literature review and others I looked at spoke to cognitive load theory by Sweller. Sweller demonstrated that students often struggle not because material is exceptionally difficult, but because it is presented in a way that often exceeds the processing limits of their working memory. He postulated that there are three types of cognitive load. There's the intrinsic cognitive load, which refers to the inherent complexity of information or concepts, which in pharmacology we can argue is pretty high. There's extraneous load, that's what distracts the learner. Ideally, we can minimize this by focusing on essential content. And then there's the germane load, which is the amount of resources available to new schema construction. And when working memory is overloaded, as often happens in lecture-dense pharmacology, students cannot effectively transfer or archive vital information into that long-term memory for clinical applications. Implementing a narrative bridge-in could provide an organizing clinical schema and scaffolding that allowed students to effectively organize and interpret this content. And this strategy reduces extraneous cognitive load, thereby freeing working memory to optimize the germane load associated with long-term learning and retention. So let's apply some ethical, technical, and safety considerations for these bridge-in narratives. So the narrative should be brief, ideally less than 60 seconds, focused, cue-centered, clinically authentic, and evidence-based. They should connect directly to the lecture content because we want to create that cognitive schema. They should avoid sensationalism, and this is the most important point for me, and that is to maintain psychological safety for students. Students might have made or experienced a medication error or an adverse medication reaction, either in their own practice as a student or as a patient or with a loved one. So we want to focus these narratives on learning and not on blame and shame. We want to de-identify real-life scenarios if they're taken from practice. Faculty should scaffold learning with this. They should encourage student reflection. They should consider utilizing some interprofessional collaboration by bringing in outside disciplines either into the narrative or even bringing in outside disciplines to come lecture on occasion for a portion of the lecture. Faculty shouldn't use this as a replacement for simulation, clinical experience, or online blended opportunities. In fact, those additional tools such as pre- and post-tests greatly enhance the full BOPPS method, according to the research. This brings us back to our PSCOT question. Among pre-licensure nursing pharmacology students, how does the use of a 60-second narrative-based BOPPS bridge-in focused on adverse drug reaction recognition compare with traditional lecture introductions in medication-related clinical cue recognition, self-efficacy, and pharmacology knowledge retention over one academic term? Professor Pat decided to test his hypothesis and this PSCOT question through a quality improvement project. He used a quasi-experimental study design that alternated between the narrative bridge-in, used as the intervention, and traditional lecture introduction, used as a control. Professor Pat compared the test performance on learning retention on content from adverse drug reactions from the lectures that he started with a narrative bridge-in, the intervention, and the lectures he started without his control. He compared the results using a pre-test and post-test. He looked at the performance of the students on clinical judgment questionnaires using NGN exemplars featuring ADRQ recognition scenarios. And he also measured their student self-efficacy using the student self-efficacy scale by Robotham and Schmitz 2023. And he expanded that to include 5 questions that were related to confidence in pharmacology. And finally, he used the concluding survey to measure learning engagement and perceived relevance for students. Professor Pat's study yielded some interesting results. In terms of clinical judgment, his students scored significantly higher in NGN-style judgment cases involving adverse drug reactions compared to their baseline. Self-efficacy was also significantly higher, and students felt both identifying greater self-efficacy and identifying safety concerns, and felt more successful in the course overall. In terms of long-term knowledge retention, the final exam performance between lectures, content that was covered with the cues and the control, which was just the traditional lecture introduction, showed a positive trend, but it wasn't significant. In terms of learner perception, students overwhelmingly reported that the narrative bridge-in increased the relevance of the content. It improved their engagement, and it helped them connect theoretical concepts to patient care situation. We'll consider that a win. And finally, this wasn't studied in the formal study design, but it was an interesting finding that there was an increase in average exam scores of 6% across the board for the students, and a decrease in course failure rates as compared to the previous 2 cohorts. So let's look at some research gaps and educator implications. This project was focused on just one part of the BOPPPS framework because it was feasible as a micro-strategy, and that's what I wanted to look at, were micro-strategies that time-crunched adjunct faculty members could use. And this existing evidence shows that the full BOPPPS method is even more successful. However, there is limited research on micro-interventions in nursing pharmacology or utilizing narrative hooks as an isolated strategy. And although there are numerous studies that examine the management of cognitive load using various creative educational strategies, there's a lack of evidence-based guidance on what's essential and what's non-essential in terms of curricular content in nursing pharmacology. In terms of advanced role implications, the study shows that a low-cost, easy-to-deploy educational strategy could be beneficial for students to help bridge that theory-practice gap. That micro-instructional strategies can help nursing educators support the National Council to State Boards of Nursing's NGN emphasis on clinical judgment, and thereby improving safety outcomes. Let's summarize what we've covered today. Students often memorize pharmacology content without recognizing medication-related cues, which can lead to patient safety issues, and this is a significant problem. We looked at a couple of different theories: cognitive constructivist, clinical judgment theory with Tanner, Novice-to-Expert with Benner, self-efficacy with Bandura, and cognitive load theory with Sweller. We examined some evidence looking at narrative learning, scaffolding, and contextualized teaching to improve engagement, self-efficacy, and clinical judgment. And we looked at some different educational practices, and we found in the literature review that comprehensive pedagogical redesigns like case-based learning or flipped classroom or even a full BOPPPS implementation does improve outcomes. However, time-crunch adjunct faculty members don't have time to implement these theories immediately. I wanted to end this with one key leadership takeaway for academia, and it's this: it's creating a new faculty toolkit. This project suggests that even small theory-informed instructional changes can help novice nurses strengthen ADR recognition and clinical judgment. Nursing schools could equip new adjuncts with this and similar evidence-based micro-instructional strategies during new faculty onboarding, benefiting both their students and their new instructors. Thank you for spending some time with me today and learning about some of these exciting applications for micro-instructional strategies. I invite you to take a look at some of the references I've used to inform this project. Thank you. And if you have questions or would like to share your experiences or ideas on other potential low cost, low time burden micro instructional strategies for nursing educators, please get in touch with me. My contact information is on the screen. Thanks for your time today.